Good evening, everyone. Endocrine emergencies. So we start with first question. It is a 75-year-old male with history of hypertension, chronic renal insufficiency, and type 2 diabetes. Is admitted to ICU with shock secondary to bowel perforation. His blood glucose is 304 milligram per deciliter on presentation and 275 milligram per deciliter on recheck an hour later. Which of the following is most appropriate for management of hyperglycemia? So you can speak the answer or you can write in chat box. It's your choice. So first option is start insulin glargine 0.2 milligram per kilogram per day and correction insulin with a sliding scale of regular insulin every 6 hours with a goal glucose target between 80 to 110. Start insulin glargine 0.2 milligram per kilogram per day and correction insulin with a sliding scale of regular insulin every 6 hours with a goal glucose target between 140 and 180. Start an insulin infusion targeting a blood glucose 80 to 110. Start an insulin infusion targeting blood glucose of 140 to 180. So what is the right answer? So what is your answer?
C, answer C.
Okay. Why C? What is the target blood glucose in ICU?
$140 to $180.
Okay, so
Yes.
140 to 180 is the
140.
target blood glucose. And answer, some of candidates have given the answer D. So there is two things to understand. One thing is which insulin you will prefer. In ICU, you will prefer always a short-acting insulin, or you will start with the infusion. And the target blood glucose will be 140 to 180. This came from the NICE sugar trial and survival sepsis guidelines. So survival sepsis guidelines are saying blood glucose target less than 180 milligram per deciliter, and other experts say 140 to 180 is the target. Continuous IV insulin infusion are recommended for glucose management in ICU patient. So you have to understand this thing. Half-life of IV insulin is less than 15 minutes and can be titrated to bring patient blood glucose level target range more rapidly than subcutaneous insulin. So we always prefer IV insulin infusion, and target blood glucose always should be between 140 to 180 milligram per deciliter. Is there any confusion? You can ask. Next. Which of the following statement is false regarding intensive target? Please mute yourself. You should unmute yourself only when you want to give any answer or you want to communicate. Otherwise, you should mute yourself. Which of the following statement is false regarding intensive glucose control? Target blood glucose between 81 and 108 milligram per deciliter compared to conventional glucose control. Target blood glucose less than 180 milligram per deciliter in critically ill patient. So they are asking which statement is false. Patient receiving intensive glucose control are 15 times more likely to develop hypoglycemia when compared to patient receiving conventional glucose. Please mute yourself. Sri Harsa Mahavedi. Please mute yourself. Option B is intensive glucose control is not associated with decreased mortality in surgical patients. Death from cardiovascular causes were more common in intensive glucose control group than in conventional glucose control group. Patients in the conventional glucose control group were more likely to have blood culture positive for pathogenic organisms. So what is your take in this? So they are asking which one is false. So somebody is saying FTTF means two options are false. So basically, this patient in conventional glucose control group are more likely to have blood culture positive for pathogenic organism. This statement is false. Patient receiving intensive glucose control are 15 times more likely to develop hypoglycemia when compared to patient receiving conventional glucose control. So basically, these two are little confusing. D is very clear that this is not the correct statement. More likely to have blood culture positive in the conventional glucose control arm rather than the intensive glucose control arm. So I am telling you that NICE sugar study was international multi-center trial, and that gives the intensive glucose control between 81 to 108 milligrams associated with 2.6% increase in mortality at 90 days when compared to conventional glucose control. More hypoglycemic event were in the intensive glucose control group, and there is no difference between the two groups in overall length of stay, ICU length of stay, time on mechanical ventilation, time on RRT, incidence of new organ failure, positive blood culture, or RBC transfusion. So NICE sugar trial is very important. They can ask question from this because this is the largest randomized multi-center trial on the topic of the glucose control in ICU. So you should read this topic or this trial in little bit detail, but I am telling you the salient feature of this trial, that no difference in the ALOS, time on mechanical ventilation, time on renal replacement therapy, or incidence of new organ failure, positive blood culture, there was no difference. But more hypoglycemic events were noted in the intensive glucose control arm. And there is a high chances of hypoglycemia in the intensive rather than the conventional glucose control. So they are asking patient receiving intensive are 15 times more likely to develop hypoglycemia. So among these two, A and D, maybe A is not 100% correct because 15 times is too high number, because they are telling this only 2.6% increase in mortality at 90 days. So anyway, among A and D, if you have to choose only one answer, then answer will be the D. Otherwise, you can say A is also wrong. So in exam, you will get some questions where two options are correct or incorrect. You have to choose best among those two. And sometimes these type of questions are deleted from the final marking. Suppose you are getting 100 questions in the exam in EDIC 1. So it might possible they will remove 3 or 4 questions for all the candidates. So they will mark only from the 96 or 97 questions. So don't worry about these type of questions. If there is any confusion, you should choose which one is the best. So A and D, in my opinion, D is the correct answer regarding this thing. You should not confuse with the 15 times more likely. That may be the reason somebody told this A is false and D is false. Okay, convinced or not?
A is true.
Sorry?
A is true, right?
A is true in this particular situation, but it looks like false because they are telling this intensive control arm has hypoglycemia 15 times more likely. So it is not true statement 15 times more likely to develop hypoglycemia, but definitely in intensive glucose control arm, there is a more chances of hypoglycemia compared with the conventional glucose control arm. Okay, but if you want to choose one of the best answer. So D will be the best answer. Okay.
Okay. Thank you.
So putting this question was the main aim was that you have to understand the real exam questions. You will find two options are correct or two options are incorrect, but you have to choose one of them. Or it might possible that question may be deleted in the final marking. So which of the following statement regarding agents used to treat type 2 diabetes mellitus is false? Metformin is contraindicated in patient with eGFR less than 60. SGLT2 inhibitors can cause hypovolemia and AKI. Sulfonylureas reduces both microvascular and macrovascular complications of diabetes. Both glucagon like peptide GLP-1 receptor agonist and DPP-4 inhibitors are associated with acute pancreatitis. So which one is false? A. So metformin is contraindicated with eGFR less than 30 ml. So this statement is false. Other statements are true. Okay. So metformin is contraindicated in patient with eGFR less than 30 ml per minute per meter square, and rest options are correct because DPP-4 inhibitors and SGLT2 inhibitors, they can be associated with the pancreatitis. Then all of the following contribute to development of DKA except insulin deficiency, increased secretion of catecholamines, glucagon deficiency, increased lipolysis. What is the answer? So less than 30, okay. DK, except D, increased lipolysis. Okay. Any other options? Everybody, somebody telling C. C. Okay. So answer is C. Basically in DK, there is a relative insulin deficiency and increased level of glucagon. So difference between the DK and HHS is that in DK, there may be some absolute deficiency in type 1 and HHS is more common in type 2. So basically absolute insulin deficiency results in increased lipolysis, resulting in increased free fatty acid that are oxidized to ketone bodies. That's why ketosis is there. So in DK, there are three things. One is ketosis, another is acidosis, and third one is hyperglycemia. Okay. So DK and HHS are very important topic when we talk about the endocrine emergencies in the critical care. So in exam, EDIC 1 exam, you will get at least one question from DK, one question from HHS, one question from CQ thyroid syndrome, one question from thyroid storm, and one question from adrenal insufficiency, and one or two questions from the calcium and parathyroid metabolism. So basically you will get from this class, you will get at least 5 or 6 questions in your exam. So please concentrate on the topics which I have selected, and this is not necessary the same question will you get in the exam, but the concept you have to understand, and you have to find out which are the important topic related to this main topic. So there are subtopics in the endocrine emergencies. You can write it down that this is DK, HHS, myxedema coma, thyroid storm, CQ thyroid syndrome, adrenal insufficiency, and calcium and parathyroid metabolism. So at least you will get one question from each of these topics. Then 27-year-old man with a history of obesity and substance abuse is found unattended. His laboratory findings are sodium 135, potassium 3, chloride 105, CO2 10, blood urine nitrogen 42, creatinine 2.1, glucose 570. ABG is showing pH 7.21, PaCO2 24, PO2 95, ketones positive. Initial treatment for him should include all of the following except normal saline at 500 to 1000 ml per hour during the first 1 to 2 hours. Replete potassium by administering potassium chloride. Intravenous insulin infusion to correct serum glucose, identify and treat precipitating event. So answer, somebody is saying C. Okay. D. Okay.
C only, because first we have to correct with fluids, then only we need to start.
So you are telling the answer is C. Intravenous insulin infusion to correct serum glucose. Okay. So you will not do this thing. So what is the diagnosis?
This is DK only, but initial assessment, initial treatment they have asked. So initially we would start insulin.
If the serum potassium is less than 3.3, potassium should be repleted before starting insulin as correction of volume depletion and acidosis. And insulin can all worsen hypokalemia. Okay, once the serum potassium is greater than 3.3, insulin should be started. So initial treatment should include all of the following except normal saline, okay. Intravenous insulin infusion, okay. Identify.
So initial treatment, they have asked question initial treatment is not the
Because potassium
insulin
is
start
3.3
after
and glucose
correction of potassium
8.
and giving IV fluids. So the answer will be C.
Answer should be C.
Yes, sir. Because first we should correct this by IV fluids and replacing potassium.
Give IV fluid and correct the potassium because potassium is less than 3.3 and then you will start insulin infusion. Otherwise, insulin will cause further hypokalemia.
Yes, sir.
Okay, so answer is C. So this is some typo error. So DK is very important, and DK algorithm you should very clearly know that what is the cutoff of the potassium. If potassium is more than 3.5 to 4.5, you will start with the 20 milliequivalent. Less than 3.3, you will start the 40 milliequivalent. If it is more than 4.5, then only you 4.5 to 5.5, then only you will not start the potassium. Otherwise, you have to start because ultimately insulin will lead to the entry of the potassium into the cell, and this will lead to the hypokalemia. Okay. So what is the fluid deficit in DK? Fluid deficit in DK is around 5 to 6 liter at least. And in the HHS, it's around 8 to 10 liter. Okay. Anyway, next question. 85-year-old male is admitted to ICU with 𝑬𝑫𝑰𝑪. His blood sugar is 720. Which of the following is true about hyperglycemic hyperosmolar state? Positive urine ketones means that this cannot be HHS. Mortality in HHS similar to mortality in DK. His free water deficit is likely higher than a patient with DK. Acidemia rules out a diagnosis of HHS. Answer is C. Everybody is saying C. I already told you that the free water deficit is higher in HHS than the patient with DK. So this statement is true. What about other statements? Acidemia rules out a diagnosed HHS, not like that. Positive urine ketones mean this cannot be HHS? No. Urine ketones may be positive in the HHS also. In DK, there is urine ketone always positive, but in HHS, it may be. And mortality in similar to mortality in DK, no. Mortality in HHS is higher than mortality in DK. So, given its slower onset, because it occurs over several days to several weeks, patients with HHS usually have greater free water and electrolyte deficit than patient with DK due to more prolonged glycosuria and lack of hydration due to concomitant illness. This results in hyperosmolar state with serum osmolarity more than 320 millimole per kg. So, ADA guidelines for diagnosed HHS: glucose level more than 600, pH more than 7.3, and bicarb level more than 20. Mortality in HHS 5 to 16%, which is 10 times higher than mortality in DK.